All right. So thank you everyone for being here today for this very important topic. We're going to get started with a few guidelines for this webinar. So in terms of how to join, you have joined the presentation listening through your computer speaker system by default. All participants will remain muted. Participants also will not be visible on camera during the presentation. Closed captioning is available through the Teams app. Please click on the ellipses depending on which device you are using. Once you click on the ellipsis, select the option to turn on closed captions. For those of you who are joining on your computer, you will have the opportunity to submit questions to the presenters by typing them into the Q&A. Please remember that, the icon that is found in the Teams toolbar. Please feel free to enter any questions you may have throughout the presentation. Note that the Q&A is not available for all Teams versions, so just please make sure you know which ones you have. Please avoid using the chat box to submit your questions. It does help us monitor them more effectively when they're all submitted through the Q&A icon. We will do our best to have your questions answered during the Q&A session at the end of the presentation. To protect your privacy when you ask a question, please do not use your name or provide any other personal identifying information. We will collect those questions and at the end of the presentation, address them as many as we can. We invite you to send further questions to ontario.programs@kidney.ca. If you have any difficulties with joining or viewing the webinar, please email our IT support at steven.bitaxi, B-I-T-A-X-I, @kidney.ca. Our disclaimer for today is that the information provided or presented in this webinar is currently, as of today, July 30. Okay, it's supposed to say July 26th. And please remember that the Kidney Foundation is not able to offer medical advice. For specific information about your own situation, please speak with your healthcare team. This information is intended for an Ontario-based audience, and this webinar is being recorded for those folks that are unable to attend. So now I'm going to present our amazing moderator for today's session, and that is Lynn Clark. Lynn Clark began her career as a human resource professional in the healthcare sector. Later, she transitioned into social community services, where she worked as an employment counselor, helping individuals to identify their unique strengths and abilities and how they can utilize them to impact the world around them. It's pretty awesome. Lynn is also married to a wonderful and supportive husband and was the primary caregiver to her 94-year-old father, with whom she did share a home with. He sadly did pass June of this year. Lynn is an avid gardener, a foodie, and loves to entertain. She is very active in her church community. As a home hemodialysis patient, Lynn seeks every day to embrace this journey and to use it as an opportunity for personal growth and development while supporting her peers as a peer support group facilitator and as a one-to-one volunteer with the Kidney Foundation. I now pass it over to Lynn. Lynn, you are muted.
That's a great way to start. Okay. Thank you, Sadia. Hello and thank you, and welcome to everyone. My name is Lynn Clark, and I'm happy to join everyone here today as a moderator of this topic. I would like to thank our patient partner and renal professional for taking the time out of their busy schedule to provide their expert knowledge and personal insights. I'm looking forward to hearing what you both have to say. I would like to introduce to everyone our first speaker, renal professional Jane Ridley. Give you a little background about Jane. Jane grew up in Stoney Creek, the Hamilton area. She obtained her Bachelor of Nursing at Laurentian University in Sudbury. She was a bit of a job gypsy, working in Medicine and ICU before spending time Outpost nursing in Northern Ontario and Northern BC. She returned to Ontario and attended Western for her master's in nursing. She taught in the nursing program for several years before becoming an expanded role nurse in the renal program. Jane had finally found her niche. Along with her expanded role nurse peers, she became a nurse practitioner. Jane spent over 20 years with the renal program before retiring from the NP role and a little over a year ago. She continues to do project work on part-time casual basis for the program. Outside of the renal world, Jane enjoys time with family, including her mini Dachshund, Penny. Jane and her brothers have accompanied their mother on journey with dementia. I understand that. They're approaching the 10-year anniversary of her diagnosis. Jane was recently invited to join the board of directors for the Alzheimer's Society Southwest Partners. Jane is an avid walker and reader. She also practices Tai Chi and is a beginner level leader in the training. She enjoys golfing and never keeps score, preferring to enjoy how the game feels. Yes, the ball went into the water, but this time it went farther before going into the water. Jane enjoys watching sports and admits to being a member of the Leafs Nation. I'm going to pass it over to you, Jane.
Thank you so much, and thank you to the Kidney Foundation for asking me to participate in today's topic. I understand we've got quite a few people joined in, and I will do my best to not disappoint. Okay, so Sadia is taking care of these slides for me. So first slide, please. This is patient-centered decision-making. We did decide also to call it driving your own bus because I think the two concepts are pretty related. Person-centered decision-making, or PCDM, was introduced with the Ontario Renal Plan 2 and has been carried over. The bottom line is we want people living with renal disease to be really active participants in their care. And the cornerstone to this is effective and compassionate communication between patients, caregivers, and their healthcare team. It also involves something called a palliative approach to renal care. And this is where I sometimes lose people or induce stress. Certainly palliative care, an important part of it is end-of-life care. But when we mention to someone that we're interested in maybe having a palliative care team member consulted, they get very concerned that we're about to deliver some very bad news to them. But palliative care is so much more than the end-of-life care. Next slide, please, Sadia. Palliative care is a philosophy of care. It's a combination of active and compassionate therapies that supports individuals and families not only with life-threatening illnesses, but life-altering ones as well. And it's holistic. It's physical, mental, emotional, spiritual. It is everything. And it's also individually tailored to the person undergoing the care. It takes into account their personal, cultural, religious, spiritual values, beliefs, and practices. So we want to respect and encompass the whole individual. Next slide, please. So palliative care involves a few things: pain and symptom management, having important discussions sooner rather than later and routinely along an individual's journey. And I'll talk about advanced care planning and goals of care conversations. It involves coordination of care and ongoing monitoring. So to me, this encompasses a lot of things that we address in our renal world. Next slide. I really believe, and a lot of others do as well, that renal plus palliative care is truly complementary care. And one of the huge reasons for this is the high symptom burden that accompanies chronic kidney disease. And I know everyone tuning in knows all about this. We know that there's a high symptom burden that can be present for years. We also know that as good as we health professionals like to think we are really not fully aware of just how severe the symptom burden can be on individuals. Symptoms are hard to treat. Kidney disease rarely occurs in isolation. There are often other health conditions involved, and sometimes it's hard to sort out what is the kidney, what is something else. And symptoms don't appear one at a time, they appear in clusters. And this makes it really challenging to manage them. And so understandably, this pretty negatively impacts the quality of life of individuals living with kidney disease. Next slide, please. The palliative approach to renal care, there's three key areas I'm just going to talk about today. The first one briefly. It's been probably about 10 years that the ORN has really brought a palliative approach to renal care onto their radar. They were keeping an eye on what was going on in the palliative world and provincially, and really began to think, well, patients spend a very long time with renal disease and in the company of renal care team people. So they sent out a survey to all the programs to determine people's education, knowledge, experience, and feelings about palliative care. The director of LHSC at the time, Janice McCallum, sent the survey to pretty much everyone working in the renal program. I'm not sure what directors of other programs did. Not surprisingly, only one group in all the renal areas had any actual education and training and more extensive experience with palliative care. And not surprisingly, that was our social work group. So I'm not going to go into detail, but a lot of work was done to work on educating, providing education, and promote better understanding of person-centered decision-making and the whole palliative approach to renal care for team members. Education for individuals living with kidney disease and their families and their caregivers is an ongoing thing. And fortunately, the ORN has some great resources, as does the Kidney Foundation. The other pieces I'll look at will be symptom assessment, management, and monitoring, and those important discussions that I mentioned. Next slide, please. Your Symptoms Matter is an initiative from the ORN. The ORN discovered that team members, renal people, were not ignoring symptoms, but they found that, for most part, programs did not have a systematic way of assessing, managing, and monitoring symptoms in individuals over time. So they generated or created the Your Symptoms Matter initiative. The initial YSM pilot involved 8 hemodialysis unit in-center in the province. The plan was after a year of this, they would roll it out to the entire province, all programs. To their credit, the ORN listened to the project facilitators who were listening to their teams and their units, and we just felt that maybe there was a little more work and needed and information gathered before this was just rolled out provincially. So there was a YSM 1 and 2. UH continued with the work they were doing with YSM in the unit until it was put on hold during the pandemic. So we have been meeting as a little task team to reinitiate and relaunch this initiative at UH. And what I'm speaking with here is largely my experience at UH. So next slide, please. Your Symptoms Matter incorporates use of something we call PROMs, patient-reported outcome measures. These are tools like the one you're seeing on your screen that measure specifically and report on health conditions directly from the patient's perspective. And this is an important and beautifully complementary piece to the assessment that the health team should be doing. There is a copy. We're going to have some resources for you we'll talk about later and will be sent to you after the presentation. The tool that we use at UH and many of the other units doing YSM is called the Edmonton Symptom Assessment System. We call it ESAS to get our tongues around it. This was initially created for cancer patients, and if any of you have experience in the cancer center, you'll know that the ESAS is filled out pretty much every time someone goes for a visit. This was revised to create a renal version. It looks a lot like the cancer one, with 3 specific renal symptoms: itching, problem sleeping, and restless legs. So this is administered quarterly. With YSM 1, we had to do it monthly, and patients and staff agreed this was far too frequent. So prior to the project being put on hold, we were administering it quarterly, and we'll resume this. So an individual, all patients in the unit, if they choose to do this, this is not a mandatory thing. They have the option to decline filling this out. are given the form, and it has 12 symptoms: pain, tiredness, drowsiness, nausea, lack of appetite, shortness of breath, depression, anxiety, well-being, and the 3 renal ones we mentioned: itching, sleeping issues, and restless legs. The person reflects over the last week, and they rate each of these symptoms on a scale of 0 to 10. 0 meaning this has not been a problem for me, and 10 being this is the worst it could possibly be. The last thing we want is for the YSM initiative to become just ticking the boxes and this being recorded. This is a stepping stone to a conversation. So it's not really the number that the person circles. It's what that number means to them in terms of how burdensome this symptom is to them and the impact on their life. So after the individual fills it out, the nurse pulls up a chair and goes through the form with them and talks with them. And there are times when maybe a 2 might be more concerning than a 7 or an 8. It's all about the conversation, what the patient shares, what the nurse pulls from it, and the nurse and the patient make a joint decision. Well, the patient decides whether or not they would like a symptom or symptoms pursued to see if we can try to make things better. And then it's a joint decision on how this progresses. The patient may have some ideas of their own that they would like to try. The nurse might make some suggestions. We have some resources we may be able to give them. Or the decisions are made to involve another member of the team. Maybe it's a nurse practitioner, the social worker, the dietitian, or the nephrologist. So it's a stepping stone for us. Next slide. I really like this slide. This was created by Dr. Mike Walsh. He's a nephrologist in Hamilton, and he heads up all of the PCDM initiatives for the ORM. He generated this slide for programs beginning to venture into the YSM initiative, as well as for programs picking it up again. And this just shows the stepping stones that YSM does. The first thing it involves is patient assessment and education. It increases patient, family, and provider knowledge of the symptoms that are common to individuals on dialysis. It also promotes tracking and recording of symptoms. This is going to help patients, families, and providers become more aware of long-term trends as well as acute changes in patient symptoms. This will also increase consistency of assessment across the board, and we're hoping improve our assessment treatment responses. We're human. Sometimes we drop things. With YSM, we incorporate communication measures and documentation to make sure that things aren't dropped, that we do remember to go back and talk to that individual about the new medication maybe we started, or we don't forget that we consulted a specialist in another area, and we make sure that we follow up with that individual's office to make sure that it is in play. Then there's symptom assessment and screening. This helps families and providers become more aware of what the person they're looking at, their family member, our particular patient, their experience with the symptoms. And it helps orient us to discussions about what's important to that person. As someone who was an NP for years in renal, I always had a list of things I was really interested and wanted to know. But by starting with where the patient, the person is at, I think it demonstrates respect. It's a way of prioritizing, because what they're going through is truly the most important thing. And by addressing their needs, I may get my own questions answered. So it really enhances communication. It also helps identify underlying health, social, and psychological issues that could be causing problems. It's pretty easy to talk about pain or restless legs or problems sleeping. But we know just from the whole mental health picture in the general public, it's harder sometimes to talk about mental health issues like anxiety and depression. Some people may not even realize what it is they're experiencing, and they may have trouble forming the words to express what they're feeling. And the tool, the ESAS, takes that out of their hands. They have it, and they just have to circle a number. Doesn't even matter what number, as long as it's not a 0. And then it's in the nurse's court to pick up on and table the discussion and open it up with that individual and through therapeutic communication, hopefully come to a better understanding of what they're feeling and make a plan on what can be done to try to help and address it. So it's an opportunity to really build a good therapeutic alliance. YSM2, I've just got to find my little cheat sheet here because I don't have this committed to memory. There was some surveying done, and 236 patients responded to a couple of two questions in particular. 42% reported that the tool helps them to talk to their team about their symptoms, and 77% reported that the teams talk to them about the symptoms they report as bothersome always or most of the time. Now, only 66 care providers responded to the question about patient-provider communication, but of the 66, 79% agreed that the tools do help improve communication between an individual and their care provider. So I think it's not overwhelmingly, staggeringly awesome numbers, but it does point to the fact that this can be of value in enhancing our communication. Then there's symptom treatment, and this is when we have the opportunity to really engage the individual in self-management. Rather than jumping to the list of 5 or 6 things we think might work, it's engaging them and saying, what have you tried? What works? What has worked for you? Have you any thoughts? Because we have some too, and you talk it out. And we're hoping to enhance their quality of life that way. We're not naive enough to think that we can fix everything. We are hoping that through diligence and not leaving too many stones unturned, we can at least take the edge off of some symptoms to make things more manageable for them. One of the nephrologists I work with, who I respect greatly, was really open with me about his concerns about YSM and getting it going in dialysis. He said, there are times when we are not going to be able to fix things. And I have a problem with patients in this position having the ESAS put in front of them every 3 months, and they're constantly circling 10, 10, 10. And it's got to be incredibly frustrating, and it's rather mean of us to do this. And I agree. And I agree it's also not fair to put the nurses, the bedside nurses, in that position to be addressing that aspect. So this is when we have to have conversations with people and sit down and talk to them and say, can you tell me how you're doing? And hearing them out and validating that you're seeing really the same thing. And being honest that you've tried these non-medicine related interventions, you've tried medicines, you've maybe referred to someone else, but being kind but honest that this is probably as good as it's going to get. And it could in all likelihood get better, or could not get better. So that leads us to conversations. So the next slide, please, Sadia. This is the important conversations, 2 components to really important conversations we have with people over time: advanced care planning and goals of care discussions. Advanced care planning is really your future care. It's generally done in a stable or well state of health. And it involves an individual taking the time to really think about their life, their health, about their personal values, their care wishes, and their quality of life. And this is not an easy thing to do, to just say to somebody, so what are your personal values and wishes? It takes time to sift through these things, and we often need a starting point. So in the resources, we have some things that we hope will help stimulate some thought so that people can come up with these things. One being the Speak Up, do-it-yourself workbook on advanced care planning. So after someone has done the reflecting and thinking about things, it's the what if. If my health were to take a turn, what do I want? And I often talk to people about a line in the sand, and the line will shift over time. On one side of the line are the things that the person is willing and quite able to put up with. This I can handle, this I will handle. The other side of the line is a game changer. These are the things that are completely unacceptable to me. The line will shift over time. So this is why ongoing reflection is necessary. But the big part of this is communicating your thoughts and wishes. You need to identify or select your substitute decision maker and have a conversation with them so they know what your wishes, values, and quality of life is all about. A substitute decision maker is just that, substitute. They only come into play with any decision-making authority if you are incapable of speaking for yourself. Next slide, please. See where we're at here. Oh, let me give you some examples of care wishes, and then I'll talk a bit more about your substitute decision maker. My apologies. Things like, I want to live as long as I can, so I will accept aggressive treatments. I want to continue working at any cost. I've suffered, and I want to avoid further pain. I don't want any more surgeries or painful interventions. I do not want to get admitted to hospital. It's important for me to die at home. I do not want to go to a nursing home. I don't want to be a burden. I want to go to my son's wedding next year. So these are all things that are really important to share with your substitute decision maker. Again, in the event that you cannot speak for yourself. We have information for you in the resources on substitute decision maker, which I really encourage you to look at because there are 9 types of them. The ones you really need to be concerned about are the ones on our hierarchy. In Ontario, there is a hierarchy of substitute decision maker, and it starts with your spouse or partner. Then it goes to parents and children who have reached the age of majority. There's one in there called parent with right of access only. I believe this has to do with parents' custody of children who are minors, siblings, and then any other living relative the healthcare team can lay their hands on to speak for someone if they're not able to speak for themselves. If you're happy with your spouse, your partner, your adult children, your siblings, or a cousin being your substitute decision maker, that's as far as you have to go. But there are times when you may want to do a power of attorney where you select someone, and it may be one of these people. The first thing you think when you hear about selecting a power of attorney is a lawyer and the fact that there are fees associated with a lawyer. There are do-it-yourself kits for power of attorney, and most renal social workers will probably have those on hand for you to do out, and you fill them out and have them witnessed, but don't bring them into your dialysis clinic or the dialysis unit because the team members are not allowed to witness these things for you. The key thing with your SDM, and think of both sides of the coin here. We all have somebody who is our SDM, whether we have a POA for them or not, just by virtue of this hierarchy. And some of us are SDMs for parents or siblings or other people. And it's a big responsibility because an SDM needs to speak on behalf of that person. They need to share the information that individual has shared with them. It's not what they think, it's not what they want, it's about that individual and speaking on their behalf. So you need to be pretty clear with your SDM or SDMs that they are willing to do this for you. And this is tricky. A lot of this is family, and we know how complicated families can be. A lady once said to me, if my heart were to stop, I would not want to be resuscitated. I would want to be kept comfortable and just let go. But my daughter is my SDM, and she says I have to be resuscitated, so I will be resuscitated. That initiated a very lengthy series of conversations on education and understanding and relationships, because a lot of people, I don't think they do things necessarily by spite, but it's hard to let people go sometimes, or to respect the fact that your opinion may differ from that person. So it can be challenging, but know your responsibilities as an SDM, and if your person doesn't speak to you, speak to them. Okay, next slide, please. So advanced care planning is a what if. What if this happens? The next level of conversation is goals of care, the what now. So next slide, please. With advanced care planning, things are in a steady state. With goals of care discussion, something has happened. There's been some kind of health issue, which could be as minor as needing antibiotics for a tooth abscess, up to something quite severe. So this is a discussion between the patient and or their substitute decision maker and pretty much a physician. There may be other people involved, social workers, OTs, physios, dietitians for extra information, but because a treatment decision needs to be made, it will be a physician, possibly a nurse practitioner, basically a medically responsible person. It can be an individual with their substitute decision maker, such as prior to my mom's dementia, when I would accompany her to appointments, it'd be an extra set of ears. Or the SDM if that person isn't able to speak for themselves. For example, a call from the nursing home saying, Jane, your mom seems to have a urinary tract infection. Her level of being oriented is worse than usual. We think she's got some delirium going on. Can we treat with antibiotics? Absolutely. Treat, get rid of the infection, and hopefully get her back to her baseline. Or it could be something more serious and that requires higher level intervention. So 2 parts to the discussion. The first is the individual or their substitute decision maker has to have an understanding of the current illness, not all the other health issues, but the current illness, the nature, the severity, and the prognosis. The second part of this is looking at the individual's goals and values and care wishes. A lot easier to do if advanced care planning has been done. Next slide, please. Because decisions have to be made and consent must be obtained. So it's got to be informed consent. Remember, there's a context. It's what the current issue is. So the capable patient or the incapable person's substitute decision maker need information and need to understand the nature of the treatment, as well as the expected benefits, risks, and side effects, as well as any possible alternative courses of action. They also need to be informed of the likely consequences if the treatment plan is turned down. Next slide. So that is substitute decision and shared decision making. You have the medical people supplying that information, and then you have the individual or their decision maker ensuring that they understand all the pieces and sharing with the medical team the goals, wishes, and values that are playing into this. Talking about that line in the sand, this would be acceptable, this would not, and together coming to a shared decision. Next slide, please. This is for everybody. I mentioned we all need to be doing advanced care planning and talking to SDMs and being responsible SDMs. I took this information, the sources, Advanced Care Planning Canada, Speak Up. This was basically, I took a snapshot of a little printout from a computer printout that was on the bulletin board in my GP's office recently about being proactive. So thinking about what's right for you, what's important to you about your future health care, learning about the SDM framework, deciding who will be your SDM or SDMs. Are you cool with the hierarchy, or do you want to go the power of attorney route? Just on that note, if you have children, if you have more than one child, if you have 2 or 6, each one of those children, adult children, gets a say. So if your kids can't agree on where to have lunch, what are the chances they're going to agree on your treatment choices if you're not able to? So if you are going with all of your children, whether it's 2 or however many, you need to talk to both of them and make sure they're clear on your wishes, goals, and values. Some people I know with multiple children will pick 1 or 2, and they often pick it out of convenience. For example, the 1 or 2 who live closest to where they are, because you may have somebody living in the States or over in Europe. So it would make logical sense to have your SDMs close by, or for any other reason you would want. But just know that more than one child, they all get equal say. So you need to be sure that everybody is in the loop on that. So you do talk to your SDM, but you also want to talk to family, friends, and care providers. Not that they're going to be involved in the treatment decision, but it makes everybody more at ease because they already know what that person would want. And it takes a certain amount of heat off the SDM. They have enough on their plate dealing, especially if it's a very intense, critical situation. They have enough to contend with, working with the team and determining the best action based on person's wishes without having to be challenged by other people. And you should record who your SDM is. And you can also record your wishes, written, audio, or video. but please don't think that that is a substitute for your substitute decision maker. If you present a nephrologist with or any physician, I would think, with your wishes and say, I don't need an SDM, this is my living will. Living wills are legal in some provinces like Alberta, but they're not legal in Ontario yet. So it's helpful to have that written down to share, but you still need your SDM aware and informed. Next slide, please. So we want you driving your own bus. I came to this conclusion fairly early in my ERN nurse practitioner career with Renal, because I realized that I only spent a small amount of their life with them. Most of it was being lived very much without my help and intervention. So I have said to people, I'm very happy to have you drive your own bus, but would it be a problem for me to be there with you with like Google Maps to offer advice that you have the choice to make? So you're here, you have a body of water, and your bus is at the other side of this pond or whatever. Person-centered decision-making is about creating stepping stones for you to cross that water and get into your bus and carry on. Some of it the team is trying to provide, like the ORN and the Kidney Foundation and your renal team, in terms of information and open discussion and communication. And some of them you're creating by educating yourself and doing your own reflection and engaging in advanced care planning and preparation for goals of care decision conversations. So it's about stepping stones to get you to where you want to be in the driver's seat of your bus, but making sure that you are equipped to make really good decisions for yourself. Okay, and Sadia, if we could move on to the resources. Shortly after the presentation today, you'll receive an email with these resources, and Sadia is just going to work this for me. The first one is an ORN resource. The link is here. It's Advanced Care Planning, Goals of Care, Treatment Decision, and Informed Consent. Probably more information than what I just presented here, but you can see the different headings there. You can just keep scrolling. It's very light on my computer and I'm squinting. So an excellent resource for you. So I highly recommend that. The next one is, the resources, Advanced Care Planning resources. I know we have some healthcare providers, some health professionals in today. So there are ones for resources for those people as well. And individuals, families, all of it. There are the steps of advanced care planning about identifying, learning, thinking, and talking, which I put up from my physician's office. We have patient symptom management guides that were created as part of YSM, and they're for people information on anxiety, depression, fatigue, itchiness, and pain. Kidney Foundation has some wonderful resources as well. And we also have the Edmonton Symptom Assessment System, if anybody's interested in looking at that tool. So I hope this has been a helpful overview for you and the resources. If anybody would like to contact me, just please go through the Kidney Foundation, and I will be happy to try to address anything else for you. So thank you for your time, and thank you to Riz and Sadia, and definitely Stephen, for everyone for putting this together. And back to Lynn.
Thank you. Thank you very much, Jane, for sharing that valuable information. I know you mentioned that it's not something that we necessarily want to talk about, but it's certainly something that we have to talk about. So thank you. I'm going to now pass it over to Riz, who is our kidney patient here. So Riz Ramaldi lives in London, Ontario. She has worked with the Kidney Foundation for 14 years. Riz is a kidney patient currently on dialysis. The diagnosis of kidney disease can be traumatic. We knew nothing about it until it happened. Riz is passionate about supporting patients through their kidney journeys. In her role as programs coordinator, she believes that there is still life after this dreadful diagnosis. We just have to find our way around it. Her spare time she spends walking, reading, cooking, and volunteering. So I'm going to pass this over to Riz. Just before I do that, don't forget to put your question in the Q&A box. Okay, here you go, Riz. Take it.
Thank you, Lynn. And thank you all for joining us today. So as you all know, my name is Rizwana. I was born and raised in Nairobi, Kenya. I was diagnosed with diabetes at the age of 9. Diabetes has been prevalent in my father's side of the family. My grandfather and all his siblings were diabetics. While they were type 2 diabetics, I was diagnosed as a type 1, also known as juvenile diabetes. So I was insulin dependent from day one. In Nairobi, in Kenya, there was one endocrinologist. He was a very good friend of my grandfather's, and he refused to see me because he was not yet comfortable with insulin. There were no resources available for me to fall back on. So I saw my family doctor every 3 months, and he did 3 things: blood work, a urinalysis, and he would check my eyes. And I wondered for the longest time ever why he was checking my eyes. Despite that, I trusted him completely. I knew so little about diabetes. I was told I could not have pop, ice cream, chocolates, or anything sweet for that matter, and that I had to take my insulin shots on time every day. Honestly, I didn't worry about this disease too much because it was not visible. That meant a lot to me because I did not want to be labeled. I thought I would be fine if I took my insulin. I went about life and school and just enjoyed being with my cousins and friends and growing up. At the age of 18, I was diagnosed with high blood pressure, and the family doctor prescribed me medication, and I take medication for high blood pressure to this day. At the age of 23, I was diagnosed with retinopathy, an eye disease caused by poorly managed diabetes. This was a really frightening experience for me. I was terrified about losing my vision. I was a Montessori teacher then and had recently become the vice principal of the school I worked at. So I underwent intensive laser treatments for the eyes for many years, and that eventually left me with no peripheral vision. So I have bumped into people, light posts, you name it, that I never saw that were by my side. This was really embarrassing for me. I got married, and a year later, I got pregnant. As soon as my family physician saw me, he let me know right away he was not happy with my decision to proceed with my pregnancy. I was almost 30 and I thought this was my one chance at having a child. So I promised to listen to him every step of the way. I had a very difficult pregnancy and spent 5 of the 7 months in the hospital because my blood pressure was so high and my feet were badly swollen. I say 7 months because my son was delivered at 7 months by C-section. He weighed only 1 kilo and spent the first 7 weeks of his life in an incubator. It was so wonderful being a mom, and I loved watching him being as active as he was. Life as a mom was busy, but I found I wasn't feeling the best. I was tired all the time. I had a bad taste in my mouth. I could not sleep, even though I was very, very tired, and my brain felt foggy. My feet were swollen since my pregnancy, and my son was now 6 months old. I went to visit my physician again, and he very quickly referred me to a specialist. Blood work was done, and I found out my creatinine was at 270. I had never heard that word before. I had no idea what creatinine was. The specialist explained that my kidney function was declining and there was no turning back, and I would need dialysis to keep me alive. Denial took over. I had thought I've managed the high blood pressure, the retinopathy, and I'm going to manage this just fine because I have a child to take care of, and he was my focus. We were also in the process of returning to Canada. Unfortunately, just before our arrival to Canada, my son was diagnosed with diabetes. It's been devastating for me because I'd hate to see him end up like I have. A week upon arrival to London, Ontario, I ended up in emerge, deathly sick. The nephrologist informed my husband and I that my creatinine was now over 1600. My kidneys had failed and that I needed to start dialysis right away. And I did. I had no choice. I have to admit, I was lost. I had no idea where this was going to lead to. As the weeks went by, I started to feel better after a few treatments. The swellings in my feet subsided. My head felt clearer. I just started to feel a little better. On the days that I didn't dialyze, I started to volunteer with the Kidney Foundation and really enjoyed the experience of meeting others that were in a similar journey like mine. I learned from them and I was able to lend a helping hand when they needed support. It made such a difference in my life. I met Jane, our presenter today. Jane would do rounds with the nephrologists and she would stop to talk to the patients, gently stirring our minds and encouraging us to learn more about kidney disease and supporting us in making decisions that we felt worked best for us. She was helping us get our independence back. It took me a long time to open up simply because I was embarrassed for the reason I had ended up where I was. To this day, I ask myself if life would have been different had I known more about my disease. Gradually, I discovered that asking questions was okay. Questions were not silly, nor were they stupid. Simple ones like, why did I need to dialyze for 4 hours instead of 3 or 3.5? Why did I need to go into dialysis 3 times a week and not 2 times a week? As I settled into the dialysis routine, it meant a lot for me to have some control. I am a bit of a control freak. So my nurses would allow me to take my weight, my blood pressure, set up my chair before I started my treatment. This really helped me feel like I mattered to my team. Almost 7 years later, I was listed for a double organ transplant of a kidney and a pancreas. The program was new to London, and this was a really exciting time, as I was told, if successful, I would no longer need dialysis or insulin. By then, I'd been an insulin-dependent diabetic for 28 years. I received this life-changing gift shortly after. I felt like a newborn. I didn't need insulin shots, nor did I need dialysis. I just loved my freedom. I went back to school and I decided to change careers. I was so thankful to our healthcare for what it had done to me. I decided to give back. Shortly after, I was offered a job with the Kidney Foundation. Life came full circle for me. I now saw a urologist because of my double organ transplant, and we very quickly built a really good relationship, and I didn't hesitate to contact him when I needed his care. Sadly, my transplanted kidney failed in the summer of 2020 after 15 years. My pancreas thankfully continues to do well. I am back on dialysis. And this time it feels different because I know more. I feel stronger because I know more about my disease. I have learned to embrace life and appreciate every day that I'm able to get out of bed. And I don't hesitate to ask questions, which I do all the time. I have learned kidney disease is manageable. I'm also waiting for a second kidney transplant from a deceased donor. This journey, as you all know, is so challenging. We have so many ups and downs, more downs, I would say. What I find is helping me is asking for help when I need it. And I encourage you all to do the same. It helps us feel better knowing that we have made that ask. Working with the program's team, our amazing volunteers, and meeting you all virtually has opened up a new world for me. A world where I don't feel alone and a world where I feel understood. I am so proud to say that I have the best of both worlds. My renal team, because I'm very comfortable reaching out to them, and you all, because we are in this journey together. I want to thank you all for joining us again, and thank you for listening to my journey. Back to you, Lynn.
Thank you, Riz. Such a moving presentation. Thank you. I would like to thank both our speakers, Riz, of course, just for your courage and just the sincerity in which you spoke. So thank you for that. And I want to thank Jane as well, just for the broad experience that you bring. And it was just obvious the passion that you have for your work and the passion that you have for the patient that you care for. So thank you very much. We have learned much, and we certainly have a lot of questions from our audience today. With that, we'll move forward with those questions. If you do have questions that you haven't yet put in the chat, please go ahead and do so. I'll start off with first question, and that is, what if your patient is not proactive and supportive? What can the patient do what if your partner is not proactive and supportive? What can the patient do in that situation? So maybe I'll ask Riz, do you think you can handle that question? And then maybe we can also have Jane comment on
that. I think we have to, I'm not going to use the word pushy, but I think we really need to let our team know how important it is for us to be heard. Because, when we are heard, we're educating ourselves, which is so important. We are the ones that have to live with our kidney journeys. And I think it's really, really important for us to, to be persuasive is what I'm going to say.
Okay, good, thank you. And Jane, any comment?
Now, was it the
partner? What if your partner is not proactive and supportive?
If the individual patient feels that they're not able to obtain that support for whatever interventions they've done, if they would like, I guess there's several options. I would lean to Kidney Foundation peer support. Maybe this person has some fears or just doesn't really know what to do. So maybe rather than sicking the healthcare team on them, although we do have some wonderful social workers who would do an amazing job, and I think a lot of our team could, maybe hooking the person up with someone in a like situation, someone, of the same, like say if Riz, I know Oscar is great, but say if Oscar is having a trouble, maybe a gentleman too whose wife partner's on dialysis and does have a child and is balancing and does work, and I know you do this with your matches. I know you try to find as many commonalities as you can, but maybe a cup of coffee, and just chatting about, because maybe you just need to start there with some peer support rather than an intervention from the team.
Okay.
We're always happy to intervene usually, but maybe Kidney Foundation for starters and peer support, and just maybe give them, like, somebody circling, a 1 or a 2 on the anxiety depression scale to just get some conversation going.
Okay, good. Thank you. That's a good suggestion. Our second question, it says, let's say 2 people are SDM and both are called, that would be SDM for your parents, and they're both called for a urinary tract infection if your mother is in a nursing home. How do they usually handle that?
The home would call, because they're not allowed to do anything without talking to. Now, there could be joint or severed, like my brother and I are joint and severed for our mom, so they can talk to one or both of us. There are situations where, whatever reason, decisions have got to be made together. I'm lucky because my brother says, you're a nurse, you know these things, you do it. But it's a matter of, just exactly, the nursing home needs to explain the situation, explain what they think is happening. Like, I think her cognition, her just mental status is off. I think she's got delirious because of the infection. If we treat the infection now with antibiotics, we can take care of it. What's going to happen? And what if we don't? Like, she's just going to get worse. The infection could go systemic, and she would, in all likelihood, pass away. So the nursing homes aren't allowed to do anything without talking to that SDM, letting them know what's going on. I happen to think my mom's we're fortunate, in a very good place, and they do call with anything that they're concerned about.
Okay, thank you. So it sounds to me like in the agreement you mentioned joint and severed.
Joint and severed. I should have it in front of me, but
yeah, I understand.
Say there are 2 of us or more of us, and that means we can make decisions together or independently.
Right.
I have a friend who did that. Her best friend was a POA with her son, and so that things could, the son down to the States didn't have to worry about doing things. But if they're not severed, or if that's the right term, and they are just joint, everything's got to be a dual decision. They've got to agree on it.
So that becomes a little bit more complicated.
It can be challenging, yeah.
Okay, good. All right, thank you. I've got another question for you. What if the care team does not agree with your decision? I can get it from both of you. Maybe we can go to Riz first, and then we can go to Jane. I don't know if Riz, if you've ever been in that position.
Sorry, Lynn, can you repeat that?
Sure. What if the care team doesn't agree with your decision? Have you ever been in that situation?
I have to say I've been very fortunate, and I haven't been in that. I haven't had that situation.
Okay, good. All right. What about Jane? I'm sure you see that at different times.
I think over time, healthcare has evolved, and it's not we say you do. It is the individual, it is their life. As long as we've done due diligence, first of all, to, explain the situation, and ensure that, okay, a classic example is somebody wanted to come off dialysis early. I don't know if most people, there was this great little cartoon, 1 or 2 books on cartoons, single frame ones, basically parodies on dialysis. And there's one with Santa Claus sitting in the chair, and there's a calendar. It is November or December 24th. And you've got the nurse, the stereotypical nurse Ratchet, going, 4 hours is 4 hours, no matter what day of the year it is. When I first started in dialysis, I would often be called to say, you've got to talk this person into staying. And it's like, why? Yes, they need it. So we need to do our best to equip patients with as much knowledge as we can, and then they can make their own decision. As long as they know the risks and the benefits of that action, it's their decision to make, and they may be assuming risk, but it's an informed decision. And just because we don't like a decision, we don't label people incompetent. You don't have to be incompetent to make bad decisions. So like any of us making a decision in life, we make good ones, we make bad ones. We just do our best to equip patients with the knowledge, and know that they're grown-ups and they can make that decision.
Okay. And they're not labeled non-compliant, or are they labeled?
Non-compliant, non-adherent. I found those labels weren't being used as much. we're only with them for what, 12 to 15 hours a week, maybe, because dialysis schedules are a lot different than they used to be. It's no longer just 3 or 4 hours 3 times a week. Some people dialyze twice a week. Some people have residual function and dialyze once a week. Some may choose just to dialyze once a week, and that is their decision. You know, non-compliant according to standard, right?
Mm-hmm.
I'm not walking in their shoes as long as, it's like this person chooses to. I mean, if we're concerned about, say, missed treatments and stuff, we actually want to talk to them and try to find out what's going on. Is there an issue with your transportation? Are there issues going on at home? Is there something else going on in your life that's interfering with this that you're reprioritizing? So try to figure out to get to the root of the behavior the best you can, but non-compliant according to who?
Yeah, okay. Thank you for answering that question. I've got another question here. It says, if I want to go back to workforce after a break or looking for a job, is it necessary to disclose my illness to the employer? How can I approach this? I'm not sure if you're equipped to answer that question.
I don't think I'm actually equipped to answer that one. Riz, do you know anything about that?
I wouldn't mind speaking to that.
Please.
Post-transplant, I went back to school, and before I joined the Kidney Foundation, I worked for another not-for-profit for a short time. And when I did interview with them, I did let them know that I had kidney disease, I was transplanted, and that I needed to go for clinic every 2 to 3 months. I found they were very understanding. In fact, they took the time when I did get the job, and what they did was they actually had a lunch and learn because my manager felt it was very, very important for her and her team to know what kidney disease was about. So I really, really appreciate that. So I have to say I was very fortunate that, learning about my disease was welcomed.
I don't know if people are required to. I don't believe there are. It's like, how old are you? When's your birthday? I mean, there are certain privacy things. So I think it's people's opinion to share, but I don't know that they have to disclose that personal health information.
Yeah, I tend to agree with you. I think as long as they can meet the requirements of the job, they don't have to disclose. That's what I believe. Okay. All right, another question here. If my kidney function is 13 over 14%, 13 to 14%, do I need to go for dialysis immediately, or can I delay since my kidneys are still functioning and I'm not feeling anything? I guess not feeling symptoms. I'm in a dilemma. Any advice would be great. I'm not sure. Can you?
Again, a shared decision between the nephrologist and the individual. And there are some people who want to defer for whatever reason. I think if they're not symptomatic and they choose, I mean, we can't haul somebody in and access their fistula or put a perm cath in them without consent. So if they choose to delay, again, just risk benefit. And if, sometimes an agreement is reached that, okay, promise you'll call me if, but we would like to do blood work. And the creatinine is one thing, because people can feel pretty unwell when they start dialysis, but you don't want a critical potassium that's going to induce a visit to the emerge department. So again, information about this. Okay, we'll defer, we'll look at this date, but I want you to call me if anything comes up. So we can't force somebody to start dialysis.
Okay, thank you.
I think just a really good discussion between the individual and their nephrologist to talk about, is this safe?
Good, thank you. One other question. I have a living will. Why do I need a SDM or a POA?
I actually did send, I wondered about this. I sent an email to one of the palliative care physicians. We're lucky enough to have two who have taken an interest in the dialysis, in the renal world. And I said, they're not legal in Ontario. And I hadn't heard back from her, but I did go to some Canadian legal sites, and very legal, a lot of jargon I didn't necessarily understand, but they are legal in some provinces. I don't believe they are currently in Ontario. And I don't know why, but I would surmise it may have something to do with the contextual, the being in context piece. You know, the living will is the advanced care planning, the what ifs, but is there enough context for the decision to be made? Like, do we need the input of somebody with just more information than what that person may have recorded, however long ago? So if and when I do hear back from the two physicians I did email, because we have two we're lucky enough to have work with us, can I send it off to you, Riz?
Yes, please do, please. And I'll be happy to share it.
Yeah.
Good. All right, thank you very much. I think that's all the questions that we have today. I don't see any more in the chat. Just double check here. I don't see anything else in the chat, so I think that's all there is.
There's
Okay.
one more at the end.
One more at the end. Oh, right here. Okay, thank you. I was told that I need to insert a catheter ahead of time for peritoneal dialysis. So if I need dialysis, there won't be any delay. I guess that's right.
Yeah, peritoneal dialysis, the catheter typically needs to be in for a little while to get embedded, because, well, Riz, I believe you did PD for a little while. It needs to get in there and get adhered to the tissue and not leak. I think they sometimes in urgent situations could do low volume exchanges, but yeah, having the PD catheter in advance and ready to go, because if it's not in or it's not quite ready for use, they may need to do short-term hemo. It's like having a fistula or a graft ready to go so that you don't need the perm cath when you start dialysis if you can avoid it.
So how soon before do you need to put that in? What's a reasonable time?
Gosh, I've been out of it so long. Riz, I'm thinking 6 weeks. I'm thinking 6 weeks.
Yes.
They might try in a month with low volume exchanges, but patients who have come, I've spoken to, have done PD, say that the leaks are pretty uncomfortable.
Okay.
So probably 6 weeks. And, you know, then you have the whole business of, you know, can it be put in? Does the person have many surgeries or any abdominal surgeries? One of our nephrologists, I'm sure there's many out there who can insert the PD catheters themselves, but if there's been surgeries and, you know, anatomy is shifted and things, they may need a surgical consult, and we know how long it takes to get the consult appointment and then book the surgery and then allow the time to wait. So we know that things aren't always as quick as we'd like in the healthcare system.
Okay, good, thank you. I think there's one more. Sadia. One final question. How do you speak with your family about POA, and what about what my wishes are?
Well, families can be complicated. I'm lucky that I have a fairly straightforward one. But yeah, it's not an easy conversation to have. And that's why I think when you go to talk to them, have the Speak Up book there and show them that you'd like to work through this. Is there a springboard or a stepping stone you can use? For example, you know, of a family or friends or neighbors who have had some kind of crisis, and maybe your neighbor over the back fence was saying, oh my goodness, this and that and whatnot. So maybe even using an anecdote to get going and saying, you know, we want things to be as smooth as possible. Sometimes you just, I think it depends on your relationship. Years ago, there was just one POA. It was a general one before, years ago, I'm really dating myself, before it split into the two, the POA for personal care as well as for estate or finance, whatever that other one is called. And my brother who's in the Navy and I were back at my mother's house in Stoney Creek. We have another brother as well. He is not active in the POA world. But we were talking, just saying, I've signed my organ donor card, just to let you know. Hope it's never used, but it is signed. And our mom, who was a nurse at the time, came through and said, I'm really glad that you're having these conversations. It's really important we talk about them. Now, my mom did advanced care planning before it was called advanced care planning, but she pulled me aside and said, okay, the boys will look to you because you are the nurse. So let me be clear. My mom, I'm not tall. I didn't make the 5-foot mark. My mom made 5'2", but did shrink over time, and she was a fireball. And she said, you just need to know that I will bypass heaven. I will bypass hell. I will haunt you to, through, and beyond eternity if you do anything stupid, and let me tell you what stupid means. And she did. So she'd clearly been thinking about this, and it was like, okay, somewhere, someday, a team is going to love me or check the will to see if maybe I'm a big inheritor. So when it came to my brothers, the one is very easy to talk to. The other one doesn't like to address these kinds of things. So we had been at the lawyers because my mom sent us to the lawyer because he was having a deal on wills and POAs. So we went to be for each other's. And we got to the car and I wouldn't let him in. It was a nice day, fortunately. I said, have a seat. We sat on the hood of the car and I made him talk. He said, it's going to rain. I said, we're sitting here until you hear me out and we start a conversation. So I took a drastic approach. So you know yourself, you know your family. Do you need a gentle entry? Is there maybe something on TV, a show or something you want, a news item, something you can do as a lead in? And just say, you know, I just want the best for you. I want the best for me. If something happens, I don't want to assume I know what you want. So can we talk? And I know a friend, she and her husband, every 5 years, they pick one of their birthdays or their anniversary or something. And every 5 years, they pull out the Speak Up Ontario workbook and look at it. Because even though they're married and partners and have an idea of what each other want, they formally revisit it. Because,
Wow.
you know, we grow, we change, our line in the sand can shift. You know, we're shaped by our experiences. So yeah, you know yourself, you know your family. Try to pick the least traumatic way of going about it. I can be as feisty as my mother, so I was pretty cool with her telling me she would haunt me.
That's good. I know pre-planning and, as you said, advanced planning makes all the difference. It's less stress for those who are behind.
And I can't say enough about the Speak Up workbook because it's a hard thing even to get your head around. Before you can even articulate things to your SDM, you need to have your own head around it. So there's questions in there that just, and it's not a fast thing. It's not something you're going to do in an hour. So you really need to let things kind of simmer back there, percolate, whatever, because it's not always easy to articulate.
Yeah, good, thank you. I keep saying that this is the last question, but there is another question. It's, if I refuse blood, can my team jump over me on the waiting list for transplant because of increased risk?
I honestly don't know.
Okay.
I don't know. I know we've got other healthcare providers out there. I don't know if there's a nephrologist or a nurse, somebody involved with the transplant world that could do the hands up thing in the chat, but I honestly, I don't know. I'm guessing no, because it's an assumed risk, but I could be way off base on that, so I don't want to commit to that answer.
And the best person to talk that over with would be their team, right?
Nephrologist, yeah.
Yeah.
Or a nephrologist, or if you're on the list, there's usually a transplant coordinator who has everything down and pat. So you could maybe call you a transplant coordinator because they pretty much know it all.
Okay, good. All right. Thank you. I'm just going to check, see if there's anything else. Seems like that's all there is. Okay, well, thank you both very much. This was great information. I know I learned a lot, and I guess there's some things that I need to be doing now that I've learned that much today. So thank you. Okay, so just moving forward, I want to let you know what's coming up, all the exciting things that are coming up. For sure, the Life After Losing Your Kidney Transplant webinar part 1. It's a 3-part series. So the first part is coming up August 3rd, 2023, and it's at 12 o'clock. So I'm looking forward to being a part of that and encourage you to register today to be a part of that program, to be a part of that webinar. And the other, of course, is Stronger Than Kidney Disease is our kidney walk. How exciting. That's going to be in September, I believe is the date. So looking forward to that. I think the locations are different. So just keep an eye out on kidneywalk.ca to see when it's happening in your location. And finally, I want to invite everyone who is not a part of the kidney support program to be, or the peer support program, to get involved. I know I started this when I first started dialysis, and it's been, I always say it's a life changer for me. And it's been just being with the people who understand the challenges that you go through, and of course, someone to share the victories with. So I encourage you, if you're not a part of the peer support group, to reach out and get some more information. And you could do that through the ontario.programs@kidney.ca or call the number that's here. And of course, there's also virtual support groups at www.kidney.ca. And the whole purpose of the Kidney Connect is that you're not alone. So I look forward to seeing those who are not there, perhaps in one of the groups. Okay, well, thank you very much. This has been very informative, and I fully enjoy just moderating the session and meeting all of the speakers. So thank you very much, and all the support that's been here. So thank you for coming, and hope to see you at the other sessions as well. Okay.
Okay, so I guess we just sign out, Riz, and